Federally qualified health centers, or FQHCs, care for more than 30 million Americans, and a big part of how they keep their doors open is the 340B drug discount program. But most people don't know much about FQHCs or 340B, or why they're both under so much pressure. Welcome to CareTalk, America's home for incisive debate about healthcare, business, and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the chairman of the Yukon Health System. Well, David, do we have CEO Scott Seidelmann on the show just to explain what you can understand?
John, that's the usual reason we invite a guest is, they're eminent in and of themselves, but also they can tell us what we should know but don't. So, yeah, Scott Seidelmann, he's CEO of NuvemRx, and they help community health centers thrive through 340B. They have software, intelligence, and expertise. Welcome, Scott.
Thank you. Thanks so much for having me.
So, Scott, tell us a little bit about what a federally qualified health center is so that we can understand the important services that your company provides to the health centers.
Sure. FQHCs, they are community health centers that is funded by HRSA, or the government, under a 330 grant. There's about 1,500 of them in the United States. And fundamentally, it's a primary care clinic that provides services to an underserved population. That underserved population could be in an urban market, it could be in a rural market, largely heavy Medicaid, quite a bit of Medicare, but also a large portion of uninsured care as well. But fundamentally, it is primary care physicians in a small clinic that treat roughly 31 million Americans that meet a criteria of some type for being underserved.
I mean, the background here, I think, David, was it started actually in the Kennedy administration and was one of the early and most effective aspects of the war on poverty to really solve the lack of primary care access in high need areas, in rural and urban areas particularly. And then it was expanded and supported pretty substantially during Obamacare as a way to solve the problem of, okay, you've got coverage now, where can you get care? And so it is really the critical link for the poorest and most vulnerable communities in rural and urban areas, and has been over time proven to be pretty effective.
To that point, John, I think study after study has shown that every dollar spent on an FQHC by HRSA saves $4 of Medicare, Medicaid, and downstream spend. And
I mean, just pause on that. That is the health research organization for the federal government that questions and tests and looks at what's the ROI. So it's a 4-to-1. Correct. Return. And that's not just those dollar savings are material, Scott, but that also means less suffering.
Absolutely.
That means more time with family, longer lives and more healthy childhoods. So it's pretty substantial because, to your point, it tends to overserve the youngest and the eldest in our communities.
And like I've spent my entire career in healthcare and have served every little nook and cranny of the healthcare market. And this is truly an inspiring portion of healthcare. These are mission driven. These are social workers that have essentially identified a need in a market that wasn't being served by a hospital. And they've applied for a grant. They don't make a lot of money. They're by definition not for profit. They can't even put put cash in their balance sheet. They're literally there just to ensure that these people who can't get care are treated properly. And it's great to watch them work.
John, it's funny that people don't know so much about these, and partly what happens, you think, well, it's safety net, it's kind of like poor person's clinic. But when you actually take a look at what they do, it has a lot of the characteristics that you describe in healthcare: primary care access, coordination, holistic care, cost effective, and really serving the community. I do know a lot about it actually because my brother, who's a primary care physician and trained in the Harvard system, runs a rural FQHC, and some of the patients, some of the wealthy patients actually try to get themselves in there once they see what's happening. So they really are quite a gem.
And so, David, maybe you and Scott could explain what the 340B program is. It sounds like an IRS problem. Like, what is the 340B program, and why is it so important?
Well, when you say you let Scott and me do it, I think let's do that and emphasis on the Scott. So what the heck is 340B and why is it important for FQHCs in particular?
Yeah, I'd love to say it's this niche-y little thing, but it just isn't any longer, right? So the 340B is an 8-page legislation that is 30 years old that essentially allows providers, hospitals and clinics that see a large percentage of Medicaid patients, it allows them to buy drugs at a substantial discount direct to the drug manufacturer. And when they do that, they can take any savings for dispensing those drugs and reinvest it back in care delivery. So it's only not-for-profit providers. It is, and you have to qualify by treating a large percentage of Medicaid patients. Now, to your point, fundamental to FQHCs and becoming a grantee, one of the biggest benefits is that 100% of your patients qualify for 340B.
So just to clarify for folks, the FQHC gets to buy the drugs for their needy patients at the lowest possible price direct from the manufacturer. But the reason why it's so important to the FQHC's financials is that they can then charge a more commercially reasonable rate to the folks who are covered. So they're actually making a margin. Correct. That effectively big pharma is subsidizing care for the neediest in society. And that was the intent of the original legislation. And as far as I can tell, Scott, it's kind of worked pretty darn well for the FQHCs because it's not that they are over reimbursed. To your point, they are thinly staffed, mission driven, and providing kind of critical last mile care. How has that program worked for FQHCs, and how important is it to the FQHC's health?
I think the program itself and what it's become is fascinating, but I think it's a common misconception. The FQHC or no hospital is charging any more for that medication. They're getting reimbursed what the commercial rate is. And particularly in FQHC's case, for someone who has no insurance, they're just passing on that savings directly. So there's no spread pricing there. I think if you take a look at the program, what is crazy and you'll appreciate is that I don't think anyone thought that the 340B program 30 years later would become a major financing program for all providers in the United States. It's probably $80 billion subsidy to hospitals and clinics in the United States today that is zero taxpayer funding. It's completely a subsidy provided by pharma. But when you put that in context, we can talk about FQHCs in a second, but even the large health systems, every major health system, not-for-profit health system, it is literally the only thing that they do that generates a profit. And it funds the rest of their care delivery, which is just insane from a healthcare policy perspective, but we are where we're at. And until someone decides to restructure the payment model, I don't know what anyone's going to do about it, right?
The tricky thing about 340B is you're taking from the most profitable part of the U.S. healthcare system, a system as a country. David may think that we should just let prices go up at any level and not negotiate them. But I would think that we could negotiate prices. But if we're not, and Big Pharma is in the position to raise its prices by the month, and they're fabulously profitable, it doesn't strike me as a bad trade to have some modest amount of those profits reinvested in nonprofits to keep them providing primary care and getting folks the drugs they need. David, I don't know whether you disagree with that, but that's sort of the policy trade that we've got that sort of sits beneath all of the acronyms and the numbers, that Big Pharma is effectively paying a modest tax to make sure that we have in a healthcare system that's very expensive, that the system can provide the care they need to people who need it.
And I think to that end, John, I think when you even look at it, the average reimbursement or the average price paid for a drug under 340B is still higher than the average price that Canada pays for that same drug. And so I think that it is, And then again, I think that's the fascinating thing about 340B. No one's saying it's good or bad. I just think that where we're at today, every hospital in the United States is subsidized by the program and it's not paid for by taxpayers, right? So I think your question about FQHCs, it's absolutely critical to an FQHC. So federally qualified healthcare centers, they have three sources of funds. Fund number one is their 330 grant from HRSA. That hasn't increased in 10 years in terms of absolute dollar amount. Two is going to be any professional component reimbursement they get from providing care on insured patients, Medicaid, Medicare, commercial. Most of these FQs, the average FQ has less than 20% of their payer mix in Medicare and commercial. So most of it is Medicaid, and we know what the margins on that look like for most providers. And the third source of funds is any savings generated from the 340B program. And what's happened over the last decade is that HRSA has not increased. Reimbursements from Medicaid will continue to decrease. The 340B program is now anywhere from 30 to 70% of the source of funds for every FQHC in the United States. So you literally, Mass General Brigham would have a tough time, very, very tough time, but the FQs would just disappear if the program went away.
So let's talk about the FQs a little bit more before getting into how the big hospitals have invited themselves to the party and eaten a lot of the cake. And you mentioned the FQHCs and the role, and John, you mentioned sort of the origin of them, but there are some differences. So you've got some that are rural, you've got some that are actually in urban centers, you've got some that are more specialized in certain areas. What kind of differences do you see, Scott, between FQHCs? They do vary a lot.
Absolutely. I think, you're going to see some FQHCs, which are extremely large. They function like little health systems in many respects. So they can see 150,000 unique patients, which should be 300,000 annual visits. In an urban center, they could have, we have, I'm sure we have many, but one very large FQHC that's a client of ours has 25 locations in the Philadelphia market, employs hundreds of primary care physicians. They employ psychiatrists, they employ a rheumatologist, they employ infectious disease docs, et cetera. I think what you see in the urban centers is the patient population, is diverse socioeconomically, diverse culturally, tends to be very heavy Medicaid, and in sort of what corresponds, and they tend to be very heavy in is behavioral health problems, STI, chronic disease management, et cetera. You can see in a rural market where there is no other provider of care, an FQ could have as few as 5,000 patients, and it could be 25,000 patients. Rural Nebraska could have 20 locations scattered across a 200-mile area. Those populations tend to be a bit more Medicare with substantial chronic disease. But back to your point, they essentially become a medical home for those folks.
So Scott, before we get into your origin story about how you got here, maybe describe what your company NuvemRx does and how you became such an expert in FQHCs because of it.
Yeah, no. I think whether you're a hospital or you're an FQHC, to fully optimize a pharmacy care delivery program, so if you are, even before you get to 340B, but if you want to provide better care to your patients through access to pharmacy, which because of 340B also generates savings, you've got to be good at a number of things. So there are several locations and ways to fill a script for a patient that has implications for 340B. Patient could present at the clinic or the hospital, and the employed physician could write a script, and that script qualifies for 340B, but the patient could go pick it up at CVS. And the clinic would have a contractual relationship with CVS, where CVS dispenses the medication, and you close the clinical loop, and then you can still capture the savings. That's known as a contract pharmacy relationship. Your employed physician could write a script and fill it in a pharmacy that is actually in your building that you run and operate.
The scripts could go everywhere.
Correct.
That would qualify for for low cost drugs that should be dispensed.
For an FQHC, which is largely primary care, treating a population of patients with heavy chronic disease, a lot of what they're doing is referring that patient off to a specialist, a dermatologist, a rheumatologist, a psychiatrist. As long as you can close the clinical loop in your EMR and prove that it was your referral, then you can capture the 340B savings if it's eligible.
And so what do you do?
So everything I just described is incredibly complex, and it requires a knowledge of 340B. It requires a knowledge of rev cycle. It requires a knowledge of pharmacy operations. It requires a knowledge of medical records. It's just really hard to do well. And so what our company does is we have developed a comprehensive service that helps optimize a program holistically across all those settings of care or places of dispense. So we combine software and experts, and we will partner strategically with a community health center to say, hey, look, pharmacy touches every patient in every setting of care. These places are not providing, they're not performing surgery. They're not, treating cancer. Pharmacy is a incredibly important service for them that they can use to treat their patients better. And it generates savings for them, which they can reinvest in other services, dental, translation, et cetera. But doing it well and getting it right is hard. And so we partner with them and say, look, we'll partner with you over the next 4, 5, 6 years, and we'll combine software and experts to help you fully optimize that. So whether or not that's filling a script through CVS, and then we'll manage, are you purchasing the drug correctly? Are you getting reimbursements correctly?
You're basically an outsourced services layer to help them optimize 340B. If they don't have you, aren't they fine?
They're going to do two things. They're going to use a bunch of different vendors to do this and have to manage through a bunch of different vendors. Or two, they're going to do it in-house, and they're going to try and do it on their own. And for a large health system like a major health system that already employs 300 pharmacists and knows how to run these programs and can invest in it, community health center, they're social workers. They don't employ a single pharmacist. And so we come in as a comprehensive service and say, look, we'll operate the entire program for you. And, we'll ensure that wherever that script is getting filled, that if you're able to capture the savings, you can. And more importantly, that you're getting a patient on an adherence program, that your primary care physician knows that the patient picked up the script, that it's refilled, et cetera. So,
Scott, let me come at it from a different angle, because there's a lot that's changed in the pharma market. So there's been a big growth in specialty drugs in particular. There's been a lot of talk about, what the PBMs are doing differently. What's the impact of changes in the drug market on FQHCs and then on into the 340B program?
Yeah, I think, look, as I described it before, if you think about FQHCs as primary care clinics that treat 31 million Americans, well, those 31 million Americans have an incredibly high incidence of chronic disease, largely at a higher incident rate than the rest of the American population. And treating patients with heavy chronic disease, whether it's dermatologic, rheumatologic, infectious disease, behavioral, you need medicines that are largely more expensive. And those are, if you want to call it a term of art, a specialty medication or just a high cost medication. And so the good and the bad of that is that the good is that community health centers, if they can get those patients on therapy, are going to provide far better care, but also those are higher cost medicines that are driving more savings. The bad of it is that it's a next level of complexity. And so we certainly are positioning ourselves to help with that.
Now, Scott, another area, and I think it ties in, is value-based care. John and I are about to release our predictions for 2026, and the growth of value-based care is one of the things that we're looking at. Are FQHCs well positioned there, or are they likely to be left behind?
No, I think for a Medicare population, managed Medicaid, I think they're exactly what you'd want from a value-based care provider, right? They're primary care physicians. They're comprehensive. They are they're a comprehensive provider. And so I think you're starting to see them enter into VBC contracts, start to take risk. Again, also very complicated. I, in a former life, spent a bunch of time in the health system world trying to connect the dots between pharmacy and downstream spend. There is an absolute linkage. It's critical. You can bend the curve downstream, but you need a very clinically integrated pharmacist. You need a pharmacist that is integrated with that care team, managing medications. And oftentimes what you see is that the pharmacy spend increases, but medical cost declines, right? Which is when you get patients on the right meds, you keep them on those meds, you get them off the wrong meds. And so I think we're pretty interested in the idea that pharmacy could play a much bigger role in helping them manage this population much more effectively.
And what would that look like, Scott?
Effectively, if they're taking risk on a patient that has, multiple comorbidities, complex disease, that FQHC and those primary care physicians and their care coordinators are trying to engage that patient to figure out, where we're getting you access to the right specialist, are we keeping you out of the hospital, all of the things that VBC needs to do. Well, what's often correlated is that patient is a polychronic, they're also a polymed. They're taking 8 to 10 different medications, and those medications are complicated. And so do we have you on a med sync program? Are you on the right meds? Why are you on this high cost med when there's a generic? What that requires is a pharmacist that is very engaged doing things that is very different than filling amber vials. It is talking with Mrs. Smith, doing med reconciliation, getting Mrs. Smith onto med synchronization, which means that she can pick up all of her meds on the third Thursday of the month. And then coordinating with the clinicians in the background to say, hey, wait, you know that she has the following complications. Should we switch this, et cetera, et cetera?
So your company's been raising your public profile quite a bit lately. I've seen the rebranding as NuvemRx. You're leaning into thought leadership. What are the sort of questions or concerns that you're hearing most from FQHC leaders, and how are you trying to address those?
Look, I would say top of mind for them right now is all about growing revenue and finding new opportunities and new ways to support their customers. I think very much top of mind is Medicaid cuts. What impact is that going to have to them? Is certainly any changes or perceived risks or concerns with the 340B program. That's top of their mind. And so I think the way we try to address those is to say, which is something they already know, is just leaning into the fact, saying that, look, that pharmacy can enable you to touch more patients, to provide better care, to fulfill your mission. And it is also the one thing that you can do, which will generate savings that allows you to hire more behavioral health therapists and hire more translation services and pay for, the ability for your patients who don't have insurance to get medications. You can cover those medications. And so I think we've just been kind of communicating and leaning into that, really.
John, last question to you.
I guess, if you have one wish, Scott, for policymakers as we go into the new year, there's a new administration. CMS is looking for lots of things to do, places to cut costs, improve technology. What's your one policy recommendation what's the one thing you want the administration to make sure they get right? Because all the FQHCs all of this is tied to regulation and reimbursement for the feds, 80% of it. And what is the one thing you want them not to do?
I think to your point, I think that the spirit and the intent of the 340B program is to really support these safety net providers, these true safety net providers. It's not in any way funded by taxpayers. And so I think that what's happening is that it's a big program. There's multiple, pharma doesn't like it for obvious reasons. And as a result, there is a lot going on in that program. I think the unintended consequence of that is that, FQHCs in particular are getting hurt by some of the changes in the administration policy. My one request to policymakers would simply be, decide to take up the program and clarify it and clean up some of the ambiguities, and just be mindful of the fact that it is a critical financing mechanism to providers that all of us want to remain where they're at and doing a great job.
Well, that's it for another episode of CareTalk. We've been discussing FQHCs and the 340B program with NuvemRx CEO Scott Seidelmann. I'm David Williams, President of Health Business Group.
And I'm John Driscoll, the Chairman of UConn Health. If you liked what you heard or you didn't, we'd love you to subscribe on your favorite service. And thanks for joining us, Scott.
Thank you very much. Great to see both of you. Have a great holiday.